Lester Layfield is from UCLA. He completed medical school residency, American Cancer Society fellowship, and he started as associate professor and developed an interest in fine needle biopsy. Moved to Duke University. He was professor, directed the surgical pathology service, and more importantly, the fine needle aspiration service. And this is where he developed a lifelong interest. Moved to the University of Utah School of Medicine, and then came here to University of Missouri, where he's the professor and chair of pathology. He's the current president of the Papanicolaou Society of Cytopathology and the co-author of more than 300 articles, 14 book chapters in 4 books. And I think we all owe him, on the behalf of our patients, a tremendous debt of gratitude for sparing our patients from open biopsy. And as we all stand here, we are also patients ourselves. And I think from that, as a personal, we owe him a personal debt of gratitude. Dr. Layfield, thank you very much for attending.
Well, thank you so much. It's a great pleasure to be here and have an opportunity to actually talk to something about that's very, very close to my heart. And that is, of course, FNA. And I'm going to focus on the pancreas, but I think it's actually a very good starting point for how diagnostic medicine has changed. We've moved from large operations to diagnose pancreatic cancer to actually reasonably minimally invasive techniques. Pancreatic cancer diagnosis is also, I think, a good way of looking at the ancillary tests, how they've been brought in to help in diagnosis, but also to help in predicting prognosis and actually very much how to treat patients. I'm going to address it from a cytopathologist point of view, but I do think it has much more interest, much broadly, for clinicians in general and GI people in particular. Pancreatic cancer is a very important cancer, not because it's so common. It's only about 2% of all cancers, but it's a particularly aggressive cancer. It's one that appears to be increasing in frequency. It's tripled or maybe even quadrupled between 1920 and 1970 in its incidence. So it is unfortunately becoming more common. And also, unfortunately, our ability to cure pancreatic cancer has not improved much since the days of Whipple. Anyway, it represents 2% of all cancers, but it's 5% of cancer deaths. And unfortunately, the cancer mortality rate for pancreas is the same, essentially, as the incidence rate. The incidence, as I said, appears to be increasing, and unfortunately, only about 30% of patients are resectable at the time of clinical diagnosis. And this just shows how much a challenge pancreatic cancer is therapeutically. Localized disease, it's only about a 50% 5-year survival rate, and that's the good news. When you get to regional spread, it's about half that, somewhere around 20-25%. And if you have distant metastases, there essentially, realistically, is no survival. It's down in the 3-4%. And that's not changed since I was a medical student. Histologic types of pancreatic cancer, there is some importance in being able to divide them up. By far and away, the most common is ductal carcinoma of the pancreas. It makes up about 90% of all pancreatic malignancies. Less common are acinar and endocrine carcinomas. In many series, these have a slightly better prognosis, but it is unfortunately only slightly better. It's still, for all of these, except for the well-differentiated neuroendocrine lesions, it's a very deadly disease indeed. Just an example so we can see what we're talking about. Moderately differentiated ductal carcinoma of the pancreas. It does recapitulate small ducts, papillary groups, as we can see in here. There's variable degrees of nuclear atypia. Unfortunately, even in small core biopsies, the degree of nuclear atypia overlaps that seen in chronic pancreatitis. So one of the most fear-inspiring cancers when you bring a biopsy to a pathologist for frozen section is pancreatic cancer, because they can overcall chronic pancreatitis as pancreatic cancer, and they can undercall it, and the frozen section accuracy rate for pancreas is lower than in most other lesions. sometimes you can find early pancreatic cancers that arise sort of off a large duct, as we see here, and then they invade the surrounding stroma. But by the time you see it, most of it looks like what I showed you in the first slide. Now, we're all wanting to find precursor lesions so we can treat carcinomas in their pre-invasive or maybe even pre-malignant phase. And there are two well-accepted precursor lesions for pancreatic cancer. The most common one appears to be pancreatic intraepithelial neoplasia. It is a microscopic lesion. It cannot be detected by imaging studies, so radiology does not help us with this at all. It is, as I said, the more common of the two recognized precursor lesions. The other is a fascinating lesion, actually, intraductal papillary mucinous neoplasm that has various degrees of dysplasia. This, fortunately, can be picked up by imaging studies, but its symptomatology is quite minimal, so often you don't get the imaging study. So the early examples of intraductal papillary mucinous neoplasm are found more by accident than by intention. And this is an example of intraductal papillary mucinous tumor. It has marked ectasia of the pancreatic ducts, often the main duct, more often the branch ducts. And lining that very ectatic duct, which you can recognize quite easily on ultrasound, and the ultrasonographers can make this diagnosis with a very high degree of accuracy, is that ectatic duct is lined by often a mucinous type epithelium with various degrees of atypia. And it's this that you can diagnose cytologically by either scraping this with a brush or by aspirating some of it off, as I'll show you in a few minutes. High power just shows that this can be quite atypical, recognized both cytologically and histologically. So this is the precursor lesion that, if you're lucky by imaging studies, you can find it and you can biopsy it. Unfortunately, most of the time it's asymptomatic and nothing brings these patients to attention until they get invasive cancer. Now, as we all know, there are a number of cancers that have nice markers and tests that you can perform to find cancer, either in a precancerous state or in a subclinical state. One is, of course, prostatic cancer with prostatic-specific antigen. This is becoming, unfortunately, more controversial because you have a lot of elevated prostatic-specific antigens that are unrelated to actual carcinoma. So I think this is going to be somewhat de-emphasized in the future. The real success story is here with cervix, and the Papanicolaou smear, Papanicolaou technique, has really made cervical cancer, the invasive large cervical cancer, essentially a disease of the past. We find by screening these cervical lesions in a pre-invasive form, they're very successfully treated by minimal techniques, cone, and sometimes even lesser procedures. And so this screening technique has caused invasive cervical cancer to be now, in this day, a rarity. Somewhat the same for breast cancer with mammograms and very successful mammographic screening programs. We're finding breast cancers either in a pre-invasive form, DCIS, which many of the small cancers found mammographically are, and also we will find the invasive cancers at a much lower stage. They will be under 1 centimeter in size, certainly under 2 centimeters in size. So the frequency or the incidence of stage 1 breast cancer at the time of diagnosis has gone way up, and of course they are all or should all be curable cancers. There are no early diagnostic tests for pancreatic cancer. We're counting on symptomatology or just plain luck. The patient comes in for another reason and has imaging studies that find a pancreatic mass. Pancreatic cancer is difficult to diagnose, and many cases are first recognized, as I've pointed out, at high stage. Symptoms are nonspecific: painless jaundice, upper abdominal pain radiating to the back. That's how 70% of them present. And as you might imagine, when you present that way, you already have regional disease. You're already high stage. Interesting run, Trousseau sign, famous French physician, described the sign and presented with the sign with his own pancreatic cancer, unfortunately. Late stage usually indicates metastasis. So we don't have any early or specific symptomatology. When you do have imaging studies, they often demonstrate a mass lesion, a cystic lesion, or obstruction of a bile duct or pancreatic duct. CT demonstrates a mass in 80% of cases. 75% of these masses are in the head of the pancreas. The remaining 25% are in the body or tail. Tissue diagnosis is difficult. Pancreas is a very deeply situated organ, and also just biopsy of the pancreas is associated with significant risks, morbidity, and indeed some mortality. And the mortality can be due to acute pancreatitis, can be due to hemorrhage. So biopsying the pancreas is not an insignificant undertaking. And you can see why. The pancreas has got a lot of stuff in front of it and a lot of stuff in back of it. It's really, if you're going to go percutaneous, it's an anterior approach, probably going through a lot of loops of bowel. There's really no posterior approach that can work. So not trivial to get there. Biopsy techniques have developed considerably over the last 20 years. Originally, pancreatic cancer would have been diagnosed when it was felt to be resectable by laparotomy with open biopsy, incisional biopsy. Then we brought on core biopsy, 14 gauge, 12 gauge. Again, I remember very much as a second-year pathology resident that a patient with suspected pancreatic cancer had a core biopsy at time of laparotomy and died within 24 hours of the pancreatitis associated with the biopsy. So this is a significant risk, even though it's just a core biopsy. The next real development was percutaneous FNA. It's anterior approach under ultrasound or CT guidance. A real-time ultrasound, I think, is the way that it was predominantly practiced, and in some sites still practiced that way. Its risks are you're passing through a lot of structures anterior to the pancreas. There are, again, risks of perforation of a viscus. There's risks of passing through the colon and infecting a pseudocyst, which can lead to abscess formation. So this has been largely de-emphasized in the last 10, 12 years, leaving us with these two cytologic techniques. Endoscopic ultrasound guided FNA, which is probably the most common now, and duct brushings of either the pancreatic duct or the bile duct. Bile duct and pancreatic duct brushings have some issues, so they're not the predominant technique. They are performed under radiographic guidance by the endoscopist. So they have fluoroscopy. The technique brushes the epithelial surface in the area of a stricture or a mass that's very close, but unfortunately it's a superficial technique. It only brushes the surface of that duct, and therefore you don't sample lesions deep to it. So it cannot be used for lesions that are distant from the main pancreatic duct or bile duct. It has good specificity. When I tell you it's cancer, it's almost assuredly cancer. Unfortunately, has very poor sensitivity. So a negative result is not very helpful. There's a lot of false negatives. There are issues with it cytologically. You can get reactive atypias with stones and stents, primary sclerosing cholangitis that can be confused with carcinoma. This is just the brush, as you see. There's a variety of brushes available technically. They have the bristles come out at different angles, which if you talk to an endoscopist, that's real important as to whether they're 90 degrees or 45. I'll trust them. And there's different lengths of the number of bristles. All of that seems to have at most minor differences in sensitivity rates. This just shows the endoscope, and then the wire guide is put through the ampulla vada and it's threaded up to the area of stricture. The stricture is brushed very vigorously, and the materials then spread on a slide and stained either by the Papanicolaou technique or air dried for immediate consultation. Endoscopic ultrasound guided FNA, it samples both pancreatic masses and cysts, so it doesn't have to be near a duct structure. You can get masses that are in the tail or the head, anywhere within the pancreas or even in the peripancreatic tissues. It is low risk from the patient's point of view. The needle passes through the gastric or duodenal wall depending on the site of the mass in the pancreas. So you can pick up gastric and duodenal contamination, which to the novice cytologist can be a significant problem in differential diagnosis. The sensitivity is good, and the specificity is excellent, as I'll show you in a few minutes. So currently, endoscopic ultrasound-guided FNA is the safest and most widely used biopsy technique for pancreatic cysts and masses. This just shows you the apparatus, the instrument. Here's the ultrasound probe head. This is, of course, the endoscope. And here's the needle. And you can get into the pancreas quite a distance and into the peripancreatic tissues. These needles are usually about 22 to 25 gauge in size. And again, just an example of the real-time ultrasound looking at the lesion. And it can be quite accurate and get into nodules less than a centimeter in size. Now, the cytologic diagnosis of pancreatic cancers is challenging because criteria are ill-defined, and unfortunately, cytology is not black and white. It's cytologists are always shades of gray. I should have worn a gray suit because we tend to see a lot of variability. It's like looking at your husband or wife. You recognize them, but if you were to write down a list of criteria as to what makes your spouse, you couldn't just put down nose, and we all have noses. So there's a lot of minor variability that to a cytologist makes a lot of difference, but they're grades of difference. Anyway, as I said, criteria are rather poorly defined and categories are poorly defined. Different institutions use different category systems, which is confusing when you try and communicate between different institutions. And also, unfortunately, different cytologists will have, within the same institution, slightly different meanings to the categories they're using. And that's where the Papanicolaou Society is trying to make differences in both what we are calling the different categories, so there's a standard nomenclature, and what the criteria are for those categories, so we all speak the same language to our clinical colleagues. Now, every surgeon wants a binary system. He wants to know, or she wants to know, is it malignant? I got to do something about it, or is it benign? And I can, hand the patient off to somebody else who will follow them, at some standard follow-up procedure. As I said, cytologists are sort of gray people, and cytologists like 3, 4, 5, or even 6 categories so that we can feel comfortable about what we put it in. But some of those categories don't communicate well to the treating clinician. I say that there's a little bit of atypia there. Well, what the heavens does that mean? I don't know. That's what I'm trying to work on. Anyway, the intermediate categories that are in the literature are dysplasia, like cervical dysplasia. You can call it just atypical cells. I could put in there funny-looking cells instead. Low-grade or high-grade dysplasia. Then we can start dividing it up. Atypia most likely reactive, meaning it's funny-looking to me, but it's not enough to be concerned about cancer. Or atypia suspicious for malignancy is, I really think this is cancer, but, heart of hearts, I'm not 100% sure. So this one is sort of when I'm particularly cowardly, not living up to my, true beliefs. But the Papanicolaou Society is proposing this system of categorization, non-diagnostic when there's either no cells, so I've got nothing to look at, or there's cells, but there's too much blood or some other artifactual change that makes it uninterpretable. Benign is just what it says. I don't think there's cancer there. I'm very sure of that. Atypical ductal cells of uncertain significance, most likely reactive. The cells are not typical, but I don't think they're malignant. They're probably due to inflammation. That's why they're looking abnormal. Atypical suspicious for malignancy. I really think this is cancer, but it does not have all the criteria to make a definitive diagnosis. And then malignant. I'm sure this is malignant. If this patient is resectable, should go to the operating room. Now, I'm not going to try and make you into cytopathologists today. We'll work on that over time. But these are the characteristics of benign biliary epithelium. And you see there's a lot of them. And each one of these has a variability, a spectrum of appearance. But what happens is that when you have a benign lesion, you have regular spacing of the nuclei, regular spacing of the cells, so that looks like a honeycomb pattern. There's orderly palisades of cells when you look from the side. All the cells have a nice columnar or cuboidal appearance, and the nuclei are at the base of the cell, right next to where the basement membrane would be. The nuclei are round or oval, and as I said, they lie near the base of the cell, so that's polarity. Everything's orderly. The cells know where they should be. Nuclear membranes are smooth, even chromatin. Nuclei are generally absent, cytoplasm pale, and there's no essentially mitotic figures, no necrosis. And this is an example pretty much of what you have for benign epithelium. These cells are pretty equidistant one from the other. It's a preservation of the honeycomb pattern. The nuclear membranes are nice and smooth. This is normalcy. This pattern, benign epithelium, can be modified by biliary tract stones, stents, and acute inflammation. And then you get into that atypia that we talked about, that reactive, where I think it's benign, but the cells are a little bit larger and they are less organized than they should be. So there's variation in nuclear size, but within any one group, the nuclei don't vary by more than threefold in size. The nuclei are a little darker. You may get prominent nucleoli. You can even have some mitotic figures. But very importantly, the nuclear to cytoplasmic ratio is normal. And that's a great key. There can be degenerative changes, and this is what reactive atypia looks like. The cells are a little more crowded together, but they still pretty much respect each other. There's not a lot of nuclear overlap. Yes, we have nucleoli, but the nuclear membranes are still nice and smooth. So a little different than normal, but not enough to be concerned about. I still easily recognize it as my wife, even though she doesn't have her makeup on right then. Cytologic features of atypical ductal cells of uncertain significance, suspicious for malignancy. We've gone up a degree in atypia, and we've gone up a degree in clinical concern. And these cells, they form groups and clusters with prominent nuclear crowding. There's not that nice spacing that we saw before. The chromatin pattern is coarser and darker. The nucleoli are bigger. There's, very importantly, an increase in the size of the nucleus in comparison to the whole cell. And this is probably the most worrisome feature. Increased nuclear cytoplasmic membrane or ratio is increased. Nuclear membrane irregularity comes up, and also importantly, there's greater variability in the size of the nucleus one cell to the next. So it's 3 or 4-fold variability, and that's important. And I think all of us can see this no longer looks like that first group of cells. They're more crowded. There's cells that are overlapping and denting each other. This nucleus is quite small. This one down here is probably 3-4-fold volume-wise the size of the other one. So, and also the nuclear cytoplasmic ratio is a little bit up there. So that one I'm pretty sure is cancer, but I want you to do something else before you take them to the operating room, just on my say-so. Now, you may well do it because the clinical suspicion is high, but the cytologic diagnosis doesn't force you to do it. Whereas if you get a diagnosis of adenocarcinoma, that patient, if they're thought to be resectable or operable, needs to go to the operating room to have this taken care of. Here we have a lot more atypia. The cells are poorly cohesive. They overlap with each other. Most of the cells are no longer honeycomb, nice flat sheets, but they're three-dimensional clusters. The nuclei just don't know where they should be, so they lie everywhere. There's nuclear molding, papillary groups, and the NC ratio is very, very high. You have large pleomorphic nuclei. You can even get mitotic figures that are no longer a mirror image. You can get a lot of necrotic debris. And finally, there's that 4-fold or greater variation in nuclear size. And this is what it looks like. Here, this is reactive atypia. There's still that honeycomb down here. And note how small the nuclei are, and they're still sort of respecting each other. This is carcinoma. The nuclei are very crowded together. There's a lot of nucleus in comparison to the cytoplasm. The nuclei are dark. You're beginning to get nuclear membrane irregularities. And you're starting to pick up mucin in there. And mucin, when you get it in these cells, it's either due to a metaplasia, which is seen in benign, but when you start to get things like this, you really need to think of carcinoma. And again, these nuclei are all quite large, and as you can see, this nucleus is a good deal smaller than, say, this one over here. So there's a fourfold or greater variation. Here's another example. Lots of nuclear enlargement, huge nucleoli. The nuclei are overlapping. This is very indicative of carcinoma. Now, major diagnostic criteria of malignancy. If you just had to name 4 things, what would those 4 be? One of the most important when you do a linear regression analysis on all the features is increased nuclear cytoplasmic ratio, chromatin clumping, nuclear molding, meaning one nucleus pushes into and distorts the nucleus of another cell, and then loss of honeycomb pattern. So these are sort of major criteria, and I think, you know, when you look at it, if you have a couple of these, 3 of these for sure, that's diagnostic of carcinoma, but even any single one of these can be seen in the benign, so you need 2 or more. Major diagnostic pitfalls. You can have sampling problems because the malignant epithelium may be covered up by benign epithelium, so on a brushing you don't sample it. You can have an insufficient sample, so you get a false negative. You can have degeneration of your cellular material due to bile that is very corrosive. Primary sclerosing cholangitis can have very abnormal looking cells due to reactive atypia, but it also can have high-grade dysplasias, and this is, for cytologists, a great problem. And there's metaplasias that can make the cells look peculiar due to stones and stents. As I said, primary sclerosing cholangitis is a cause for both false positives and false negatives. It can be associated with reactive atypia, it's associated with a series of dysplasias, and it is associated, as you know, with an increased incidence of adenocarcinoma of the pancreaticobiliary system. So this is a cause of both false positive and false negative diagnoses. Well, how do we do cytologically or diagnostically? We can see that bile duct brushing accuracy, sensitivity is 40 to 60%. It's a flip of a coin. I'm not telling you much. You could go out with your own coin in the hall and decide whether it was benign or malignant. If I tell you it's benign cytologically, but if I tell you it's malignant, that's very, very secure, 90 to 100% specificity. And this is just a series of publications. You can see, as I said, sensitivity somewhere in the 40, 50, maybe as high as 60%. Specificity is very, very high, upper 90s to 100%. So when you get a benign diagnosis, what's the frequency of cancer? If the cytologist says it's benign, frequency of cancer is somewhere between 40 and 60%. We don't know what the frequency of cancer is when we call it one of these atypias, but when we call it malignant, the frequency of cancer is about 90%. Diagnostic accuracy, that was for brushing. Diagnostic accuracy of EUS FNA, better. Sensitivity is variable, but usually pretty close to the 80s to 90%. Specificity, 98 to 100% in the reported series. Let's look at that table again. So I call it benign. The risk of malignancy is usually about 10 to 20%, although some of the poorer reports it's up to 50%. But I think when you call it benign on EUS, about 20% of cases will have carcinoma. Atypical, not otherwise specified. The cytologist just calls it atypical. Interestingly enough, when you look at a large series of those cases, 80% will be carcinoma. However, if you call it atypia of undetermined significance, favor reactive, in this study, none of those were malignant. If you call it suspicious for malignancy, 84% are malignant. If you flat out call it malignant, somewhere between 98 and 100% are malignant. So this group here signifies a set of patients that had carcinoma, or extraordinarily high risk for carcinoma. Want to emphasize final diagnosis of pancreatic mass or stricture requires correlation of clinical findings, imaging studies, and cytology. So triple diagnosis. which is sort of the watchword for FNA. Well, how can we improve accuracy of EUS in brushing cytology? There are a number of things we can do, ancillary tests. There are advances in imaging. There's intraductal ultrasound, CEA levels, KRAS point mutations, fluorescence in situ hybridization, which I'll talk about more. DNA analysis, is it diploid or normal, or is it aneuploid? Aneuploid generally corresponds to carcinoma. There's tumor suppressor markers and loss of heterogeneity. Intraductal ultrasound is a very safe and readily performed procedure. It produces very detailed images of the duct system, so you can get more information that way. But it's not a tissue diagnosis. It's generally good diagnostic sensitivity and specificity, but the results are poorer in primary sclerosing cholangitis. But again, this is an imaging result. It's not a tissue diagnosis. CEA cyst fluid analysis, it's done on cysts, as the name would indicate. Very high CEA levels suggest malignancy, and there's these sort of cut points shown here. But CEA today is used mostly for determining whether it's mucinous or non-mucinous. And it's, if the CEA is above 197, it's probably a mucinous lesion, but that can be a benign mucinous cyst. If it's below that, it's probably more of a serous lesion in its nature. KRAS point mutations, there was tremendous hope that this would solve all our problems, and this was one of the first sort of markers that was used in molecular diagnostics for the pancreas. KRAS point mutations are very common in biliary tract and pancreatic carcinoma. About 70% of carcinomas will have a KRAS mutation. Their p-value for association is 0.001, so that's a good association. But unfortunately, KRAS mutations are found in benign hyperplasias and some metaplasias. In fact, when you look at some large series of the hyperplasias and reparative lesions, fully 17% will have a KRAS mutation. So its specificity in some of the larger, more recent series is a good deal lower than this 93%. The literature is divided on the utility of KRAS mutations. So I tend not to do them because a negative has some importance, but again, fully 30% of cancers don't have KRAS mutations, and a positive 17% of benign lesions will have KRAS mutations. This just shows you where KRAS mutations come up. KRAS can be found in early, essentially metaplastic processes like Panin-1A, which is one of the precursor lesions I talked about, and then it continues up in frequency all the way through cancer. But it's that it occurs very early in this scheme of metaplasia to dysplasia to cancer that makes it a poorer ancillary test than I'd like. One of the very exciting things is to modify the Eurovision technique, pancreatical vision as it's sold as now, and this looks at numerical changes in chromosomes 3, 7, 17, and band changes in 9, p21. And it seems to have a very good sensitivity and specificity for carcinoma, and indeed, many, many institutions are using this technique not only on brushing material, but also on FNA. And this just shows you what one of these FISH studies looks like. Normal benign would be 2 probes of each color. And you can see here we have 1, 2, 3, 4 for that red probe, which I think is 7. So it is tetraploid for 7, it's triploid for the blue probe, and again tetraploid for the green. So this is highly abnormal, and this is indicative of carcinoma. It is known that FISH analysis significantly improves diagnostic sensitivity without loss of specificity. The probes are commercially available, and it's most useful in cases when the cytology is negative, but the clinical is positive, or you have an inconclusive cytology, one of those atypias I talked about. DNA analysis depends on how much recoverable DNA you have. It can be used on the cyst fluid prior to brushing. You can actually just take fluid off and run this test on the fluid, even though there's no cells in it. You can see the difference in mean concentrations of DNA. CA125 analysis of cyst fluid. It's moderately useful in separating benign from malignant cysts. but unfortunately there's a lot of overlap between the benign and malignant CA125 levels, so it's not used much clinically after a lot of hope that it would be very helpful. Similar tumor suppressor linked and microsatellite allelic loss. Basically, it's a rather difficult multi-step methodology. It's not performed in most hospital or even larger laboratories. It probably is not as good as the fluorescence in situ hybridization of fish, so most people don't use it. And sort of in final analysis, fish testing appears to be the most useful of the ancillary testing methods, and I think the widely held recommendation is that fish testing should be performed on clinically suspicious but cytologically negative brushing specimens and all equivocal brushing and FNA specimens to optimize diagnostic accuracy. And I think that's it. I'll take any questions. Hopefully I didn't run over too much. Any questions? Because I think this is a nice paradigm for how cytologists now approach many lesions, whether it's pancreas or lung, thyroid, that there's the actual cytology component, and then there's a battery of ancillary tests. Yes?
On one of your slides, you showed a paper where he was at like 85%.
For
all the way down at the bottom of the slide in terms of his.
sensitivity?
Yeah, did you look at that paper?
Yeah.
Why he was so far outside where everybody else was?
Some of these are very small series. Some of them, it's how you define what your false positives and false negatives are, because some papers will say, well, I will put all the atypias in with the malignancies, and that increases your sensitivity. Others will say, well, the atypias are a different category. I don't include them as false positive or false negative, and that's probably more realistic is what it means to a clinician. So that's the problem with some of those papers, depending one on size, depending on follow-up, because some of them will unfortunately also take and say, well, my follow-up will be any histology that we have plus 2 years follow-up, and if they're alive in 2 years, then it must have been benign. And if they died within those 2 years, then it was malignant. And that really does contort the accuracy of those sensitivity and specificity ones quite a bit. And that last one, it was really an outlier. As I recall, it was not a particularly large series, and I think it was constructed so that when there was doubt, it was put in such a way that it improved sensitivity.